A pancreaticoduodenectomy, pancreatoduodenectomy, Whipple procedure, or Kausch-Whipple procedure, is a major surgical operation involving the pancreas, duodenum, and other organs. This operation is performed to treat cancerous tumours on the head of the pancreas, malignant tumours involving the common bile duct, duodenal papilla, or duodenum near the pancreas, and also some cases of pancreatitis with or without a definitive cause. History: this procedure was originally described by Alessandro Codevilla, an Italian surgeon, in 1898. The first resection for a periampullary cancer was performed by the German surgeon Walther Kausch in 1909 and described by Kausch in 1912. It is often called Whipple's procedure or the Whipple procedure, after the American surgeon Alan Whipple, who devised an improved version of the surgery in 1935 and subsequently came up with multiple refinements to his technique. Anatomy involved in the procedure. The most common technique of a pancreaticoduodenectomy consists of the en-bloc removal of the distal segment of the stomach, the first and second portions of the duodenum, the head of the pancreas, the common bile duct, and the gallbladder. The basic concept behind the pancreaticoduodenectomy is that the head of the pancreas and the duodenum share the same arterial blood supply. These arteries run through the head of the pancreas, so that both organs must be removed if the single blood supply is severed. If only the head of the pancreas were removed, it would compromise blood flow to the duodenum, resulting in tissue necrosis. In modern medicine, the Whipple procedure today is very similar to Whipple's original procedure. It consists of removal of the distal half of the stomach, the gallbladder and its cystic duct, the common bile duct, the head of the pancreas, duodenum, proximal duodenum, and regional lymph nodes. Reconstruction consists of attaching the pancreas to the duodenum and attaching the hepatic duct to the duodenum to allow digestive juices and bile respectively to flow into the gastrointestinal tract, and attaching the stomach to the duodenum to allow food to pass through. Whipple originally used the sequence, bile duct, pancreas and stomach, whereas presently the popular method of reconstruction is pancreas, bile duct and stomach, also known as child's operation. Originally performed in a two-step process, Whipple refined his technique in 1940 into a one-step operation. Using modern operating techniques, mortality from a Whipple procedure is around 5% in the United States. Pancreaticoduodenectomy versus total pancreatectomy. Clinical trials have failed to demonstrate significant survival benefits of total pancreatectomy, mostly because patients who submit to this operation tend to develop a particularly severe form of diabetes called brittle diabetes. Sometimes the pancreaticoduodenectomy may not hold properly after the completion of the operation, and infection may spread inside the patient. This may lead to another operation shortly thereafter, in which the remainder of the pancreas is removed to prevent further spread of infection and possible morbidity. Pylorus-sparing pancreaticoduodenectomy. More recently, the pylorus-preserving pancreaticoduodenectomy is growing increasingly popular, especially among European surgeons. The main advantage of this technique is that the pylorus, and thus normal gastric emptying, is preserved. However, some doubts remain on whether it is an adequate operation from an oncological point of view. In practice, it shows similar long-term survival as a Whipple's, but patients benefit from improved recovery of weight after a PPPD, so this should be performed when the tumor does not involve the stomach and the lymph nodes along the gastric curvatures are not enlarged. Another controversial point is whether patients benefit from retroperitoneal lymphadenectomy. Pylorus-sparing pancreaticoduodenectomy versus standard Whipple procedure. Compared to the standard Whipple procedure, the pylorus-preserving pancreaticoduodenectomy technique is associated with shorter operation time and less intraoperative blood loss, requiring less blood transfusion. Post-operative complications, hospital mortality and survival do not differ between the two methods. Morbidity and mortality. Pancreaticoduodenectomy is considered, by any standard, to be a major surgical procedure. Many studies have shown that hospitals where a given operation is performed more frequently have better overall results. A frequently cited study published in the New England Journal of Medicine found operative mortality rates to be 4 times higher at low-volume hospitals than at high-volume hospitals. Even at high-volume hospitals, morbidity has been found to vary by a factor of almost 4 depending on the number of times the surgeon has previously performed the procedure. De Wild al. have reported statistically significant mortality reductions concurrent with centralization of the procedure in the Netherlands. One study reported actual risk to be 2.4 times greater than the risk reported in the medical literature, with additional variation by type of institution. Nomenclature, Fingerhut al. argue that while the terms pancreatoduodenectomy and pancreaticoduodenectomy are often used interchangeably in the medical literature, scrutinizing their etymology yields different definitions for the two terms. As a result, the authors prefer pancreatoduodenectomy over pancreaticoduodenectomy for the name of this procedure. References. External links: the Toronto Video Atlas of Liver, Pancreas and Transplant Surgery, a Euro video of Whipple Procedure, the Toronto Video Atlas of Liver, Pancreas and Transplant Surgery Patient Education Module, a Euro Patient and Family Education video for the Whipple Procedure, Whipple Pancreaticoduodenectomy, a historical comment, Adrian O'Sullivan, a Euro, the original description of Whipple's operation together with a modern commentary.